Good morning from Miami. This is Dr. John Bennett. We have another Neurosurgical Super Sunday with Hype Cherian presenting on cisternostomy. And I'll first introduce members of the panel before we turn it over to Hype. Hello, Andrea.
Hello, everyone.
Could you say a few words about where you're at and who you are, Andrea?
Yes, I'm Andrea Gerosi in Italy, and I say hello to everyone. I've been with Dr. Cherian for the 3 months last year, a few weeks ago, and hello, everyone.
Okay, welcome, Andrea. Shuga, welcome.
Hi, John. My name is Sugar Hinojosa. I'm a neurosurgeon from Peru. I also have been with Professor Cherian like about 1 year ago for 4 months. My main interest is in trauma, and I found cisternostomy really interesting procedure and really outstanding in this new era of neurosurgery.
Okay, welcome, Sugar. Can we meet the residents behind you, please?
Yeah, so we have Mohammed here from Egypt, he's a surgeon, and we have Jocelyn and Edmundo. They are both neurosurgeons. Jocelyn is from Mexico, and Edmundo is from Peru. So, in fact.
Okay, very good, Hype. It's all yours. Take it away.
Now, good evening, everybody. We are on to Neurosurgical Super Sunday today. Do you know, I was actually talking to the president of the World Federation today, and he's a good man. He's made a lot of changes, in fact. But Western perspective is that the rest of the world should get funds, publishing, and research. We're talking about neurosurgery. So if we get funds for publishing and research, it's better. This is what the West thinks. Now, let me give you a small example. 5/6 of the world, we do not have gamma knife. We do not have, most of the places do not have microscopes. Most of the places do not have coiling. It's good surgical technique. The only thing that can be done good in this country is surgical technique. If you don't promote surgical technique in these countries, and if you promote only research and paper writing in these countries, we'll have a, sorry to say, but we will have a complete set of surgically incompetent guys in these countries where they cannot afford it. Well, in the United States, if you have an incompetent surgeon doing a tumor, skull-based tumor, you can gamma knife it. You can radiate it. If you have an incompetent surgeon who's not able to do an aneurysm, they can go for coiling. If you have an incompetent guy doing trauma, you can put them in the ICU with cooling and whatever, not multimodality monitoring and whatever Hutchison or rest of the guys say. In these countries, this is something that all of us has to realize. So the Western perspective that they're doing a favor by giving neurosurgeons a grant for writing something or publishing something is actually working against these countries. What they need to do, what the WFNS needs to do, is to establish cadaver labs and teach these guys how to operate. Africa, Latin America, India, China, Nepal, everywhere. Don't put emphasis on research, please. Put emphasis on microsurgical techniques. Otherwise, believe me, they have spoiled a generation. We have a lot of guys, senior and semi-senior guys who believes in writing articles and not really training surgeons in clipping or in microsurgical technique. This is wrong. This doesn't work for us. So that is why today I'm not at war with anybody, as I had told my friend, a very good friend, Franco. I mean, Franco supported us a lot for sure, but his perspective, Hutchison's perspective, all needs to change because, you know, they are affecting our younger generation to think that research is important, more important than surgery. Only when surgery is done, you can do research on surgery. If you're not doing good surgery, how on earth can you do good research on this surgery? Finally, we will end up doing research and publishing papers on techniques of skin incision and things like that, or even maybe injections, because that is all we will be doing finally. So this is what I want you to change. I want the 5/6 of the world to realize that you need to be good surgeons first, and then you publish. Believe me, if you have taken up neurosurgery, if you are not publishing, you're still a neurosurgeon. But if you are not operating, you're not a neurosurgeon. This is the most important thing. Otherwise, go into neurostatistics, go into neuro data collection, or anything what you want. If you are a neurosurgeon, first learn your surgery process. Because that is what classifies you as a neurosurgeon. And that's very important. If you think publishing is important, it is not. It is not important in the face of not learning good neurosurgery. So all of you, whether you're from Africa, Latin America, India, China, Russia, anywhere, go to labs, learn surgical techniques, and after that, go to masters, see surgeries. You know what you see as surgeries in conferences are edited 2-minute, 3-minute videos where everybody presents their best cases and you don't understand what it is like. So first you have to go to the cadaver lab. You need to understand the anatomy. You need to understand the 3-dimensional anatomy. And after that, you need to go to the masters to learn what surgery is like, what are complications, how do you handle them, what is the success rate. In conferences, you will never understand. In conferences, we show beautiful edited videos of 2 minutes. So go there and then you are ready to do surgery. Do surgery for 10 years. Be a semi-master at least. And then you think about publishing. Don't start publishing the moment you get out. You think that, oh, I have 5 papers, I have 10 papers. This is not good. This is what the world is coming to. And I believe this is wrong and the WFNS has to change this. All over the world, people has to change this policy of putting priority research over surgery. So starting with that, I'm going to give you a presentation which I gave 6 years back. Nothing has changed, you know. Nothing has really changed. And this 6 years back, what we did, I will present today. Most of the boys here, they have seen cisternostomy. They have done cisternostomy. They have first-hand experience in cisternostomy. It's microsurgical technique, and it's definitely advantageous over gross surgical technique. That it is common sense. You don't really ask evidence for it. I can tell you, when DHC was accepted as a norm, how many papers were there to support it? Even today, after 130 years, there are not many papers to support it. So how can we say that that is gold standard? To be gold standard, it has to be proven. How many times DHC has been proven? So why hold on to a surgery which has no roots in itself, which is based on a wrong statement, which is not microsurgical, which only gets patients to be robbed of their dignity. I say in a harsh language, we could say you're converting a cemetery to a vegetable market. That is what you are doing. So, except that you're not doing anything good. Everybody is proven that. Now you say there is a little bit of advantage here, there's a little bit of advantage there, but we've all done enough decompressive hemicraniectomies to understand that it doesn't really have an advantage, especially in severe head trauma patients. You can talk about a subdural, you did a DHC and then the patient improved. Well, I have seen these kind of cases many times. We put the bone flap back in these kind of cases. You don't need a DHC for these kind of cases to start with. But when malignant brain swelling happens, I can show you a few cases and then you will understand that what we're talking about. Okay, today, let's start off by saying what Machiavelli, Italian. Are you there, Andrea? Niccolo Machiavelli, he talks in his Prince, in his very, very famous or infamous book, The Prince. So there is nothing more difficult and dangerous or more doubtful of success than an attempt to introduce a new order of things. It is true even after so many years. It is true. You want to start something new? It's always the most dangerous thing on earth to do. Right. Now, why cisternostomy? And why not decompressive? First, we will talk about why not decompressive. You know, what is decompressive hemicraniectomy? It is the removal of portion of a skull to create more space to the swollen brain and relieve intracranial pressure. First described by Coker in 1901, although it was done before that. Now, what Coker said precisely is this. He put a needle into the lumbar area. He did a lumbar puncture. Although Coker started ventricular, Coker's point is there, but you know, he used to do these decompressives based on lumbar puncture measurement of ICP. So they did a lumbar puncture and they found out that CSF pressure was not elevated. So that is when he said, if there is no CSF pressure, but brain pressure exists, then pressure relief must be achieved by opening the skull. The first part of this sentence is wrong. The second part of this sentence is also wrong. But for Theodore Coker, that time, it was common sense. He thought the CSF pressure is not elevated. Why don't we open the skull and relieve the pressure? But imagine if Coker had figured that the CSF pressure is high. Instead of this, if he had put in a cisternal catheter, then Coker would have said, there is CSF pressure, and because of that, CSF is going into the brain, creating pressure. Let us open the cisterns. That's what probably Coker would have said. This is because he did an LP and figured that there's no CSF pressure. These are his words. So cisternostomy, my friends, is based on a wrong conclusion, on a wrong statement, starts off with a wrong statement. And you guys have followed it like a tradition for 120 years without having any real evidence. And all of us knows what the results are. Yet, in the developing countries where it is mostly hit, when there is a new surgical technique which has come up for 10 years, which follows microsurgical principles, and many people have told about its results, You're still asking for evidence. You're still asking, where is the evidence? And when you want to publish something, if there is an evidence, you want to publish some things, the journals will not allow you to publish because, well, there are a lot of vested interests. The companies who sponsor bond cement, titanium plate, ICP monitors, these are the companies which endorse many journals. I've never said it out aloud, but this is the truth. Everybody knows it. It is not a secret. Everybody knows it. Most of the bigger conferences are endorsed by these companies. And for the neurosurgeons, it's a good thing because as a senior neurosurgeon, you don't have to go in the night, do some trauma because your resident who doesn't know much can manage the decompressive hemicraniectomy. Any idiot can manage a decompressive hemicraniectomy, by the way. He can manage the decompressive hemicraniectomy. He can talk big stories about malignant brain fungus or brain swelling and all that. And then he's going to close and he's going to come. You can collect this data in the morning and present in some conferences, which is endorsed by all these companies, which gives you ICP monitor, which gives you bond cement, which gives you titanium mesh. It's easy. It's an easy life. Think about these patients, please. If it was somebody you knew, would you really do it after knowing that microsurgery would have helped this patient? Even 10%, 20%, and we are not talking about 10 or 20%. The people who have been with me has seen these cisternostomy patients. So I'm going to show you some cases as well. Now, I'm going to tell you again about CSF shift edema and the Monroe-Kelly doctrine. Monroe-Kelly doctrine says that CSF, blood, brain are three things in the compartment. And Monroe-Kelly doctrine is wrong because CSF and brain interacts. It's been proven many times over. CSF gets into the brain for cooling and cleaning through Virchow-Robin spaces. If you guys have not read the recent papers, read Clarica's papers, read Nedegard's papers, read our papers. Okay, there is basic science research, very good evidence that CSF enters the brain through Virchow-Robin spaces. Okay, so Monroe-Kelly doctrine is wrong because CSF and CSF and brain communicates. So therefore, CSF can get into the brain. And or how on earth do you think the cisterns are not seen after a trauma, 2 hours after a trauma? You don't see the cisterns at all. And when I ask a neurosurgeons, group of neurosurgeons, they tell me they got compressed. It's impossible. Believe me, if you know hydraulics, it's impossible. You cannot compress 100 ml of fluid. The brain is swollen, cisterns are not seen. A child will tell you that the CSF went into the brain. About 100 ml of CSF went into the brain. And when you do a decompressive hemicraniectomy, what you're doing is, it is a 12 into 10 centimeter, 12 into 10 centimeter defect. You are allowing 1 centimeter or 1.5 centimeter of brain to herniate into that defect. That is what you're doing by doing a decompressive. Whatever CSF went into the brain, you're allowing that brain to herniate out into the defect, causing axonal stretch, severe damage, and severe brain matter loss. So this is not something that you should be doing in developed countries, also in developing countries. This is a common sight. These patients, they call these surgeries about technical advancements in decompressive hemicraniectomy. I'm telling you, I'm being harsh. They might as well say about technical advancements in murder. So I don't think you can talk about technical advancements in decompressive hemicraniectomy. The damn surgery is wrong. Now, if DC decreases ICP, why are outcomes no better? They are no better because ischemic changes have already occurred, associated primary diffuse axonal injury, axonal stretch caused by shifting the brain bulk. Paradoxically, the release of pressure may accentuate development of brain edema and hinder recovery. Okay? This is not my sentences. These are all from studies. Okay? Now, let's not go into all that. This all has been discussed so much in detail. I'm going to tell you about what cisternostomy does. Again, I've been telling about this for 10 years. So, there is cisternal subarachnoid hemorrhage in trauma. This is common. Cisternal subarachnoid hemorrhage in trauma. The cisternal pressure goes up to almost 50. Through the Virchow-Robin spaces, CSF discharges into the brain. And that is what cisternostomy does. You put a drain there and let out. And so these are type 1 VR spaces. Type 2 and 3 VR spaces, Virchow-Robin spaces. Trauma, this is what happens. CSF gets in, brain is edematous. That is what DHC does for you. That is what cisternostomy does. Well, the G lymphatic pathway and all these pathways and evidences have been told so many times. Okay, let's get into scans now. Well, this is the scan where the GCS 4/15, both pupils dilated. Okay, 2012, beginning, we were starting our cisternostomy. We were doing cisternostomies with decompressives many times, and then we started putting a thin bone flap. We started doing a large temporal decompression, and then we started putting a small flap. You can see that flap there. But before that, let me show you things. Okay, see this scan. This is 4/15, both pupils dilated. Okay, there are no cisternal spaces at all. Brain is almost black. Okay, now there's multiple contusions. What we've gone and done is we have opened, you can see that thin plate of bone there. This is muscle. That is the brain boundary. That is the brain boundary. We didn't take the cisterns, we just opened them. Okay, we didn't take any contusions, we just opened the cisterns. You can see the open cisterns here clearly. Now you see this kind of a damage. You remember this guy's name now. I'm going to show you this guy before he even leaves the ICU. Okay, his name is Sanjeev Preti. नाम क्या है? क्या नाम क्या है? बोलो. Sanjeev Preti. You can see that the sutures are still there. That means it's before 7 days. Okay. Imagine a CT scan. Imagine the CT scan and see the result. With decompressive hemicraniectomy, this guy would have been in coma probably for 6 months, and after that he would have been vegetable. See this one. Okay. Again, you would do a decompressive hemicraniectomy here. The brain is going to herniate because you see the CP angle cistern is widened. It's near herniation. There are many who would tell me I would just remove the contusions on both sides and leave it. But see the edema. See the edema. Many would say, okay, I would do a decompressive hemicraniectomy on the left side. Okay. See what we did? We kept the bone flap back. There was a small extradural hematoma. He came walking 8 weeks later. We didn't take out even the contusions. There is a contusion here. Took out these contusions which came out. The main thing is cisterns are open. Okay. There's a small extradural hematoma which would never have been there if the pressures were high. So, right. Let's see some more. So, this is a patient with a classical subarachnoid, traumatic subarachnoid bleed. And then when it is severe, he was GCS 14/15. And then he deteriorated to 4/15 with the right pupil dilatation. So we went ahead and took this out. Severe brain swelling was there, but subarachnoid. So just like an aneurysm, we took out all the, we opened all the cisterns, and after opening the cisterns, brain was lax, kept this back. Disease was 14/15 at discharge. Residual right third nerve palsy was there, which improved in 6 weeks, 15/15 in 6 weeks. Another patient, GCS 4/15, right side pupil dilated. In fact, when he was brought to the emergency, his GCS was much better, but he deteriorated to 4/15, and we were called in immediately. We thought this was the initial scan, but you see, immediately after the procedure, you see the damage. And here the brain was so swollen, so we put in the catheter here, and you can see the damage here. And with this damage, we will show you when he's getting discharged, we will show you what happened. This is when he was getting discharged. At discharge, next one. You see, CP angle cistern is not only widened, herniation is already started. You can see the herniation starting. The midline is, if you allow some more time, this midline will go out of this skull. You see the midline shift? That is the midline shift. So I'm sure many of you would have agreed for a decompressive hemicraniectomy here. I cannot think of anybody who will not. See the edema? So what we did a cisternostomy, kept the bone flap back, and took out that contusions. Edema is still there. This is the guy. He's not even discharged from that ICU. He's still with the cap on. He's probably in the ward. Okay. Right. Next, presenting GCS 7 with anisocoria. So you can see the extensive damage. Discharge GCS 15. Okay. Now, okay. Another one. 6/15, left pupil dilated. No cisterns at all. Absolutely no cisterns. Okay. Really, really severe brain edema. So severe brain swelling, tentorial herniation noted with contused third nerve, cisternostomy done, brain lax and pulsatile. Okay. Right. Many of the boys here has seen even minimally invasive cisternostomies where we have gone in with just 5 centimeters. And then after once you reach, it's a difficult task to get into the cisterns, but once you get into the cisterns, release that CSF, brain is pulsatile and lax. Okay. Only case when we don't get that is ischemic brain. Okay, another case, GCS 40/15, both pupils dilated before surgery. Okay, you see this brain. The brainstem is almost elongated. It's black. The brain is black. Okay, 40/15, both pupils dilated. Young woman, Okay, very young woman. What would you do? Bilateral decompressives, Gelberg, topectomy. We just did a cisternostomy. You can see how much retraction I had to make. You can see how much retraction I had to make. And after this retraction, you see how this brain is. You can see the cisternal catheter, which is actually not placed properly. But the brain is lax. After the cisternostomy, the brain is lax. This is the retraction injury. People tell me, oh, do you have retraction injury? Yes, we have retraction injury. But see her on the 7th postoperative day. Okay? She still has this. That is her on this. See this brain. See the brain stem. Okay? And you see the post-op scan. We've taken out the PF posterior fossa hematoma. And after that, we did a cisternostomy, and this is the guy. This was all done 6 years back. Now see this case. I'm not telling you these kind of cases should be operated and you'll have fantastic results. No. 4/15, both people's dilated. So brought to the hospital within 3 hours of trauma. See the brainstem. Okay. What would you do in this case? Bilateral decompressive. See the damage on this side. See the damage on this side. What choice do you have? ICP measurement. Okay. If you put in an ICP catheter, I'm sure brain will come out through that. You probably, have brain in your ICP catheter. You know what I'm talking about. Okay. So we went ahead, did a cisternostomy. And this is immediately after the cisternostomy. Brain is lax and pulsatile. I'm not saying the brain, it is magic so that we cleared everything. No. Okay. No. I'm saying the brain is pulsatile and lax. Okay. That's what I'm saying. That's what this surgery can do. All right. This is a discharge, the same guy. See him. Now, operative technique. You must understand that I did a mistake when I started off with operative techniques, which are very, very tough. I talked about unlocking the brain because I was a skull-based guy. And I talked about opening axial unlocking, sagittal unlocking, all those nonsensical things. I was wrong. Okay, I would accept that. And it scared away all the neurosurgeons who even wanted to try it. So for many years, I was alone. Till 3 guys, Wang, Roy, and Parthiban took it up. They came and told me, see, listen, you can talk about cisternostomy, but it's very simple. So there was this guy from Iran also, he published sometime, and he said you didn't have to do anterior clinoidectomy, posterior clinoidectomy, or anything like that. Opening membrane of reliquis is important. But once you go through the initial storm, get into the cisterns, open the cisterns, wash out the blood. It's a rather easy thing to open the next things. Open the next cisterns, put in a drain, come out. Help you a long way towards your microsurgical training. Instead of doing a decompressive hemicranectomy, having the brain come out like toothpaste, trying to close, somehow standing on the head, trying to close it, and then have a semi-dead patient next day morning. So operative technique, well, it's much simpler than what I described it the first time. Okay. Let's see a few. So this is a frontotemporal craniotomy with severe brain swelling. See the brain coming out. As soon as you open, the brain is coming out. That is after the surgery. See how lax it is. You see the damage, but how lax it is. It's not coming out of the brain, coming out just like before. Well, we've talked a lot about posterior clinoidectomy. Let's not go there. Let's not go into skull base techniques and all that. Do a simple, proper, simple pterional craniotomy. Take your sphenoid ridge out, open, go subfrontal over the orbital roof, okay? Removing PCP again. Don't even see it, okay? See it if you are basilar quad. This is something that you will see. That is a contralateral third nerve, okay? This is a video 6 years back. So that's a basilar quad. Very useful for basilar aneurysms and things if you are planning to go that way. Well, if you're planning to publish, this is suprabrow technique. Please don't ever think about it, okay? Don't even think about it. So, well, the complications of cisternostomy is something that we must discuss. Of course, it's not an easy surgery. So definitely there are complications. So the thing is to get experience, and to get experience, you must do something. You will not get experience by talking or publishing, okay? To get experience, you have to watch first, and then you have to do it. Otherwise, you're not getting experienced. So go ahead, as young neurosurgeons, get out of your comfort zone. Don't listen to the West saying that you must get funding for research. No, as long as you're neurosurgeons, first justify that name, that you're a neurosurgeon. So go to the cadaver lab, learn. After that, when you're competent, start publishing. Okay, I'm not saying don't publish, but moment you finish, you start having papers, there's something wrong with the system. You end up as publishers, neuropublishers, and not neurosurgeons. Okay, so don't do that. Well, there are some lessons that we learned. Final bottom line is this is not a panacea. This is not something that'll cure everything in the world. No, we learned that. But it's definitely way, way better than, I would add way, way, way better than decompression hemicraniectomy. Okay? So we have papers. No, these are the initial papers. Now we have chapters. If you type in World Neurosurgery, you will have enough. Acta Neurochirurgica just published another paper with a scathing review from Franco and Hutchison. Okay. Well, about Franco, he's been of help. Hutchison, I can only say he collects data. He collects very good data and publishes very good stuff. Whatever is done by his residents, he collects in the morning and publishes that in a nice way with good English, and also goes and presents it in large conferences. I really don't understand why this is something great, okay? I don't know why he should even be called a neurosurgeon, with all due respect. He should start operating. If he is a neurosurgeon, he should start operating, okay? This is my challenge to him. This is what I have to tell him. If he can write all these scathing reviews, but he will not be able to stop progress. He will not be able to stop what we are doing. And he doesn't have the perspective of developing countries, our countries, where what we need to do is we don't try to ape the West by getting gamma knives in every villages, getting coiling in each villages, getting multimodality monitoring in each village. It's impossible. Try to learn surgery. Go to cadaver labs. Every medical colleges have cadavers. Go learn. And after that, be with some masters, start surgery. This is what you should do instead of aping the West. So, thank you very much.
Okay, very good. Thank you very much. Okay, any comments or maybe we can meet the new arrivals. Dr. Manbachen, could you introduce yourself to IPE, please? Are you there, doctor? Let me see if I can get him. you need to unmute there? There you go. Oh, possibly can't get through. Dr. Cabullo, could you say hi to Hype?
Hello, Professor Hype. My name is Kabulo. Yes. How are you, Prof?
You're from Tanzania.
I'm from Congo, but I'm in Zimbabwe, training in Zimbabwe. Yeah. I have two questions, Prof.
Yes.
Hello?
Yes, we can hear you.
Yes. Yes, I was saying, is there a timing for surgery for cisternostomy? Because all patients are not coming at the same moment when you are receiving them at the hospital. That's one. And the second one, it's in case you get bilateral acute subdural hematoma and you want to do cisternostomy, how do you proceed? Do you start with the hematomas or you do one side and cisternostomy? Thank you.
Good questions, both excellent questions. Now, you know, in our part of the world, we have helicopters bringing in patients or ambulances bringing in patients very fast. So we have a problem. So patients can come very delayed. The only thing you have is when you should not do cisternostomy. One thing is if the motor score is 2 or less and the brain shows signs of ischemia, this is not a good time to do cisternostomy. Maybe you should stick to decompression, okay? Because there is ischemia. But if the brain is not showing ischemia, if the motor score is, you know, at least 3, then it is very good. This is a good time. So don't wait. Don't put in an ICP monitor and cook that patient on a slow fire, okay? Go do the surgery first. If you think that this patient needs surgery, don't have any doubts. Don't put in the ICP and say that it is 27 now, tomorrow I will wait, and by the time it is 40, you want to do a decompressive, everything is over. So do proactive surgery. So to answer to your first question is, there is no time, only time when not to do cisternostomy, I can tell you. Okay? Otherwise, any patients come to you, do it. Okay? If it is indicated, of course, you don't catch somebody off the street and then do cisternostomy for them. Obviously not. So you have to have indications for this. If you have indications that these patients need cisternostomy, of course, you do it. Second answer. The second question was, what was the question? Bilateral.
In case you have bilateral, yes.
Subdural needs to be evacuated for sure. Okay. So I start off with the thicker subdural. Wherever is the thicker subdural, I evacuate it, do the cisternostomy, and then go to the other side. You know, once I make the cisternostomy, the brain is going to be lax. I go to the other side, I evacuate the subdural. If there is a subdural, I evacuate. If it's very, very thin, I don't. But if it's a reasonable subdural, I will evacuate it, but I don't need to do a cisternostomy. And also, I'll be, after the cisternostomy on one side, I'll be able to easily put the bone flap on the other side.
Yes, Prof, are you not fearing the brain to expand, the other hematoma to expand when you are draining the thickest one? The moment you are doing the cisternostomy, the brain will relax. The other one won't expand, the small one.
Don't think too theoretically. Okay, we are surgeons. Okay.
Whoop, okay. Don't know what that is.
Extradural anterior dorsal technique.
I don't know. I think that's on your computer, right?
Okay. So did you see that? Okay, now let's go back. How do we go back? No, it's not sharing. It's, can you hear me?
Yes.
Okay, I just put it in the center. All right. So don't think too theoretically. Okay, when you do the cisternostomy, the brain immediately turn on the other other side, don't worry too much and then just do it, okay? It's whether the brain will expand. If it expands, you go fast and take it out, okay? Take the subdural out. Don't think too much, you know. Do you know about the story that three doctors went for hunting the ducks, you know? And one was a psychiatrist, one was a pathologist, the other was a surgeon. So they went to hunt the ducks, and the psychiatrist said, I think I see a duck, a partridge, but maybe it's my delusion, you know, or maybe it is a hallucination. So the pathologist, he said, it could be, you know, a partridge, it could be a parrot, it could be something else. So the surgeon took the gun, shot it, and said, okay, let's see what it is. All right, I think it's a duck. So that is what a surgeon is. They don't really wait, and that really signifies a surgeon. With all these research and everything, we have literally screwed with our brain, okay? You must know, you must be able to focus on to one thing and hold on and latch on to it, and then go do it. This is what we are for. We do not sit and analyze. There are many people who will sit and analyze. You know, today I saw a surface lesion, completely surface lesion, and they are sitting and analyzing what it is. I said, take it out, and then you will know what it is. Okay? So, Kabulo, my answer to you, I want you to start, when I want you to come here, okay, like your friend Gracian Guenero, who came here.
Yes. Yes.
I want you to come here. I want you to see cisternostomy firsthand. Okay? Stay with us,
Yes,
like voice. Stay with us, see cisternostomy, see aneurysm surgery, see skull-based tumors. Okay? Learn. Come to the cadaver lab. Do enough cadaver dissections so that you have some confidence about doing things. Take the exam, then go back with flying colors. Start doing good surgery in your place. After 10 years, you think about research, my dear boy. Don't think about it before that, okay?
Thank you so much, my professor.
Okay.
Right. Any other questions?
Sugar, you have any comments that you would like to give? I mean,
I think one point that Professor Chirian made really clear is the necessity of improve our skills. The problem with cisternostomy is that it's challenging to do it. I mean, it's not everybody can do it. You need to develop some skills. And that sometimes, especially for senior neurosurgeons that don't have this much practice, is difficult to understand. We talked with Professor Servadei in China about the necessity to improve neurotrauma. And I think the concept of included microsurgical technique and skill-based techniques to trauma is good. We have seen the results. But one really important point that Hira also told us yesterday is the necessity in this era of evidence-based medicine. We need to collect our data and put it together so that way we can prove. That way we can prove that this is working. It's difficult for, not everybody can go to Nepal and see how is all this been done and how magnificent it is in the surgery itself. But for us that we have been there, it's a challenge to start to do it in our countries and put the effort together and collect our data in a systematic way so we can prove other guys, especially you know who, that we are right and they are wrong.
One thing, Sugar, I will tell you something, you know, when Jesus Christ entered Jerusalem, made a statement saying that, you know, if these people don't hurrah for me, the stones will hurrah. You understand me? I'm telling you, 10 years they asked me for evidence. 10 years they told me, do these trials, that trials. I never listened to them. today we are not alone. We have a huge group of people who believes in us. Because we don't do anything, we do things for the greater good. We don't do anything to glorify myself or glorify somebody else. We do things for the greater good of people, the greater good of society. We are not companies with vested interests. We are not with big journals who will look for p-values and that values. Let me ask you one single thing. How many papers did a neurosurgical drill have before it was validated? How many papers did the CUSA have? How many papers did the microscope have before it was validated for surgery? How many papers did decompressive have before it was validated? So-called validated. Neurosurgery developed in the era of no evidence because we don't lie and we have common sense. Let them not influence you by saying that you need evidence for everything. You don't need evidence. Okay? It is a wrong statement to say that let Hutchison jump out of an airplane and say that, I will say that with parachute, I will say that, okay, let us do a study. I think without parachute, he will survive. And he can say only with parachute, he will survive. Let us make a study like this. Do you need evidence for this? You don't need evidence for this. Why do you need evidence for something so obvious? 100 years old surgery versus microsurgery. Do you think you need evidence? Experts doing surgery versus residents doing surgery. Do you need evidence? Improvement of surgical skills versus going back in surgical skills. You need evidence? It is so bloody obvious, I'm sorry. But yet, you know, they want to hold on as much as they can. And we have been influenced in a way. It's like a Barbie doll. You know, if a child, you know, it's so influenced by Barbie, if you give a toilet named Barbie, she will take it. I'm telling you, it is branding, it is in your brain, that evidence. Most of neurosurgery's advancements were in the era with no evidence, where people were good surgeons. British neurosurgery is finished because of evidence now. There's no more, I mean, I can see a few good people who really doesn't care about evidence and does good surgery. But otherwise, rest of the guys are just evidencers, p-valuers, publishers, collectors, data collectors. Don't get into this trap of evidence. I am being sentimental or emotional, but believe me, this is a trap these guys have set up in the last 50 years. They started giving funding for research to neurosurgeons. Don't take this funding for research, it's nonsense. Learn neurosurgery, believe me. Learn neurosurgery. If you want funding for research, go for something else. Not for neurosurgery. You finish your residency and then you start a research. What nonsense is that? You have to learn how to operate and it will take you 10 years. So, with all due respect for research, do research. You're a semi-master. Never before that. Okay? And when people ask for evidence, laugh at them, not on their face, but laugh in your heart. Tell them, remember, the stones will hurrah. Okay? If they don't, the stones will hurrah. I'm telling you. Each young neurosurgeon who comes out, we will be able to tell them it is correct. And when something is correct, you cannot stop it. It's like trying to stop a lightning strike. This is what I told Franco. It's like trying to stop a lightning strike. Can you stop a lightning strike? If you try to stop a lightning strike, you'll be burnt. All you will hear is a sound. Okay? That is what will happen to people who will try to stop progress in neurosurgery. Okay? They have stopped it for 50 years. We have a generation of neurosurgeons who doesn't know how to research, who doesn't know how to operate. Frankly, I'm telling you, 5, 6 of these neurosurgeons are in developing countries. They read papers and they get orgasms reading papers and p-values, but they don't know how to operate. Most of them, they don't use microsurgical techniques. They don't teach anything to their juniors. This is what is happening. Get out of it. Go to cadaver labs. Learn. Be with masters. Be with people who are willing to teach you. Okay? Let them waste away. Those are the guys. They're now. Okay? You should give them a good funeral party. Bye-bye. All right. This is what is needed now. So, we are neurosurgeons. We're supposed to have real balls in handling things, real balls for every other thing. We're radical people. We are probably psychopaths. And that's why we took up neurosurgery. It's not easy to clip an aneurysm and then go on and do an AVM and then do a skull-based tumor where the results are not so good. It was 100% mortality before. These people were psychopaths. Survived that. That is why neurosurgery improved. We're not here to sit on a cushion of papers and some academic positions and some companies supporting us doing bloody surface meningiomas and writing papers. No. So, when somebody asks for evidence, no evidence. Okay. Still now. When these guys try to get me to their side by telling me, okay, you should have a randomized control trial, I say, thank you, honey. Thank you, sweet, sweet guy. No, I don't need evidence. I've been doing this stuff for 10 years, and I'll do it for another 10, or another 10, or another 10. And then there'll be people to follow. There's no question about that. Remember, the stones will hurrah. If people say I'm mad, let it be so, because I would like to go that way. Okay? But I'm sure after one more generation, people will realize that microsurgery is very important for neurosurgeons. Not some ICU multimodality monitoring and p-value and all that nonsense. Okay? Remember that, please.
Sorry, Prof.
Okay, very good. Very good.
I have one more question.
Go ahead.
Yes. Prof, I'm going back to cisternostomy. I saw most of your cases, once you are done with the cisternostomy, the brain is relaxed, very relaxed. So do you usually replace the bone, or in some cases you don't replace the bone, you do a craniectomy?
Yes, I always replace the bone. Most of the time we replace the bone. My boys also, consultants also replace the bone, except when we have any doubt whether the brain is relaxed or not. If the brain is not relaxed, then even after cisternostomy, we do not keep the bone flat back. Because cisternostomy is not to prove a point to anybody. We are not saying that we can always put the bone flat back. No. If the brain is not relaxed after cisternostomy, there's no need to put the bone flat back. So in these times, we don't put the bone flat back. That is very rare these days. Now all my consultants are doing it. So it's pretty rare for us to see that the brain should, the bone flap cannot be put back. But some of these cases are out of inexperience also. So, of course, when I started learning, I had a huge learning curve. And now these boys, the consultants that we have here and the fellows we have here, their learning curve is much smoother because I have made all the mistakes. And I can tell you what mistakes I made and you can learn from it.
Thank you, Prof.
Welcome. Dr. Manbachan Singh, do you have any questions? Are you there? I don't think he's here. Okay, right. Yes, John? John, you're muted.
Dr. John, you are muted.
I'm sorry. I guess I'm going to fire that director. Okay, I thank you very much. And we'll continue this next. Thanks all the guests for coming. Okay, we're going to stop the recording.